That's what I want to start doing. Okie dokie. All right, grab your books. We're going to start injuries to the spine. I'll be right back. I'm going to grab my book. Yeah, sure. Last one? Yeah. Okay. Yep, I will. Oh, yep, I sure will. Kathleen? Okay. I will. Oh, where it was? Gotcha. All right. Okay, see you. Thanks. All right, I am going to show you a picture. And I'm going to show it to you. So in between, on break, whatever, we'll bring it back up and discuss it. But I'm just going to show you a picture, which I wish we were in class. And I want you guys to just put down what you think your treatment plan, what you're going to do for this patient, and some of the things that are going to be most important. So it's a physical assessment, an isolated injury. And I want you just to take a look at it and tell me what, as far as if you were assessing the patient, what are some of the things that you want to consider? And I'm going to show you it. Can you guys, let me take it out of the shear stuff. Does that help? Can you guys see that okay?
Lights and sirens drive fast.
Yeah.
Okay.
You're asking us, what are we identifying?
So everything else looks good other than the patient's a little shocky, but you see this. What I want to know is what is going to be your treatment plan when you see that. And just in between, just write down what kind of things that you're going to be thinking about the most, that is going to be most important. If you could ask me anything, what would you want to know about this patient? And what would you be assessing as you looked at this? So this is the only injury. This is all you see. Okay? So obviously,
surfing in shark-infested waters.
Good question. All right, I'm going to start spinal, and we'll come back to that. I just want you to think about that. All right, and I just want to make sure we're recording and everything's good. Okay, so let's talk about injuries to the spine. And before we move into spine, I'm going to just recap on intracranial pressures. So we talked about last week signs and symptoms of ICP, or intracranial pressure. So what are your typical signs and symptoms of intracranial pressure that you would expect to see that would identify it from everything else?
Bulging eyes.
Okay, possibly. Yep, that might be one of the first things, but I want to know vitals.
Increased blood pressure, decreased heart rate.
Okay, so increased blood pressure, so they're hypertensive. And increased heart rate, right? Tachycardic. What else? What's that?
Jane Stokes. The
Ooh,
breathing.
I love it. All right. Respirations are regular or irregular?
Irregular.
Irregular. Shane Stokes. What are Shane Stokes respirations? What do they sound like?
Deep and rapid.
Deep and rapid with
Periods of apnea.
Right, with periods of apnea. So deep rapid with periods of apnea. That's because of the pressure that's getting put on the brainstem as it increases. So intracranial pressure, high blood pressure, a high increased heart rate, right?
Decreased.
Decreased heart rate, yeah. increased or irregular respirations. My mind's thinking where it's going next and I'm confusing myself. We have increased blood pressure, decreased heart rate because it's putting pressure on that brainstem, and we don't need the heart rate to increase as much as we need the pressures to decrease, right? And then the irregular respirations. This is respiratory, right? Okay, so now I want you to tell me in hemorrhagic or hypovolemic shock, what is the, I'm just going to put hypo V shock. What's the blood pressure?
Decreased blood pressure, increased heart rate.
Okay, when does decreased blood pressure happen?
Once we're decompensating.
Decompensated, yep. So if they're in significant shock, we see decreased blood pressure. They get hypotensive. What happens to the heart rate?
It increases.
Increases, so they get more tachypnic, right? All right, what happens to the respirations?
Increase.
Increase.
Increased. So remember, we're just dealing with bleeding and shock, so we have that decreased blood pressure if it is going into a decompensated, and that's what we're looking for. Initially in compensated, it stays the same, but we might see a little bit of tachypnea and a little bit of tachycardia. But as we get into decompensated, how could we tell the difference between these two? Well, increased intracranial pressure, because of the pressure that's building up in the brain, we have an increase in blood pressure. Where in bleeding and shock, we're losing volume. We're not losing volume here. That's the difference, okay? Hypertensive versus hypotensive. In this one, we might be having pressure on the brainstem that keeps the heart rate from being able to increase, or we just don't need the increase. So the body's not telling it you need to beat faster, but you need to have more pressure to try to get through the swelling that is going on in the brain. Where in decompensated bleeding and shock, we just have that increase in heart rate because we need to circulate blood more. We need to circulate what's in the blood more. That's not the problem here. We don't have blood loss. We don't need to circulate what's in it more. It's there. It's just that because of the pressures that are happening inside the brain, it is not able to get through. So it's got to increase the shove, increase the pressure. So it vasoconstricts and tries to increase how much it can move through. So we see that difference. So I want you to understand bleeding in shock versus increased intracranial pressure. Now, of course, our respirations are going to follow the heart rate in bleeding and shock, because if we're losing blood, not only do we need to move more blood, we need to add more oxygen to blood. So we have to increase both of them. But in this one, when we have pressures, if you think about the location, okay? So if you think about the location of where the pressure is at, and when we think about the brain with the vasomotor center, the respiratory center, all of that being in the head, it makes total sense that if you start squeezing something, you're going to see things change. So if you squeeze it, what happens when you squeeze something? It gets tighter and has more pressure, right? And this heart rate drops, and that's why we see irregular respirations, because that it's like called an apneustic center, but the vaso and respiratory center that's there is unable to relay those messages as well. And so because of that pressure, it is all over the place. We see those rapid and then
Why'd you throw it, bud?
periods of apnea.
Sorry.
Oh, that's okay. So I want you to know the difference between those two, because tonight we're going to go into neurogenic shock and we're going to talk about spinal shock. So you've got a lot of shocks that we have learned. Remember, we learned cardiogenic, hypovolemic. We'll have neurogenic or vasogenic. Remember, we talked about that. We have distributive shock and all these different kinds and types of shock, which really localizes and tells us what is going on in the body that's causing the deficit, what's actually going there. Septic shock, respiratory, there's lots of them. Metabolic for our diabetics, all of that kind of thing. So that's what I want you first to understand, the difference between increased intracranial pressure and hypovolemic shock, so you can recognize the difference in a scenario. You need to know that. If you can recognize these symptoms interchangeably of what is going to happen in those type of patients, seeing it in a scenario, you're answering top end questions, and you'll have less questions, and you'll thank me for it, because that will get you out of that test faster. Because when you get the whole all-inclusive of what's happening, then you can answer those more tough questions, and that's how you get through the test more quickly. But having like 75 questions versus having 125 questions. So answering those top end questions and really understanding what happens and why is important. Now we're going to do like 2 weeks of practicals. We're actually going to just have availability to do practicals. I'm hoping as after the 28th that they'll open up. If they say we can have 10 people, then I'm bringing you all back, and we're all going to be doing practicals together. If they don't, then we're going to split you into groups of 5 and or 6, something like that. And I'm going to bring you back to the classroom, and we're going to work in small groups, and even maybe some one-on-ones if we have to, so we can get you through it. But I'll give you scenarios with this in it. I will have you manage patients with these, so you can actually apply it and you can actually work through it. But I need you to be able to recognize right now in a scenario, in a question, because that's what's going to be most important as far as we go on. All right. Any questions about that and the differences between those two? And if you don't understand the differences, that's what else I want to know. If you don't get it. Do you get it? All right, so let's talk about a few things. We're going to talk about neurogenic shock, but first we're going to talk about the nervous system. What are some of the first things that come to your mind about the nervous system? I hope I got enough room to write this. I'm going to move this over the camera so we can see more board. That did not work. I'm going to move it back and there. Let's see. What are
FYI, why do they have that light stay on all night?
You have to shut, I know, when Matt rewired the projector in the ceiling, the light stays on. So you have to go shut it off on the power box in the electrical room. I forgot to tell you that.
I'm just going to tell you right now, Mike Smalley was millimeters away from having to put the light bulbs back in.
Yeah, I know. They finally figured out just shut the power off in here, and that's what
Oh, that's awful.
Okay, so when you think of the nervous system, let's think of a system, right? What do you think of?
The
Brain
spinal
stem.
column.
Okay, the spinal column. Who else said something? What was that?
I said the brain stem.
Okay, so the brain. All right. What else do you think of as far as the spinal column and the brain and how they work together for the nervous system? How does the nervous system respond in the body? Some of the things that you could think of.
The medulla.
Okay, the medulla. Yep, it definitely has some effect on it. But how does the body respond to nerve stimuli? You have 2 mechanisms in your body we learned in anatomy and physiology that happen as a result of the nervous system. So what 2 reactions would you remember that are results of the nervous system?
Involuntary.
Okay, involuntary and voluntary. Now we're getting somewhere. And what else? I'm going to write it.
It's like
Sympathetic, sound familiar? Parasympathetic systems, right? You're like, what? I know you guys know. So 2 different responses that we have to stimuli. So either it keeps us, we're calm and everything's fine, or something scares us and we're not, okay? So we have that parasympathetic, which we consider the feed and breed, right? So, and we have the sympathetic system that is the what?
Fight or flight.
Yep, fight or flight. Okay, so the nervous system is constantly working to be able to accommodate things that happen. And this sympathetic nervous system not only responds to fear, the body responds in that way by injury, okay? So if something happens, you instantly cut your leg. Do you think you kick back on your sofa and this feed or breed, kind of like, whatever, man, I'll take care of this later? No, your body responds by, uh-oh, I'm bleeding. We've got to do something here. I need to constrict those vessels. We need to send out the army to start the clotting process, the whole 9 yards. And your heart rate will increase. So that sympathetic and parasympathetic system is constantly going through and balancing within your body for different needs. So remember we did I'm just going to draw a parachute kind of here. So this comes down if we had clouds in the sky. Remember parasympathetic, the balloon, we'll put some hearts on our balloon. Basically, oh, that looks like mouths and eyes. Anyways, it's supposed to be a balloon. Where sympathetic, fight or flight. So parasympathetic, that's slowly coming back to relaxation. Sympathetic, those big eyes like, oh my goodness, right? What's going on? Fight or flight. All right, so what is our typical signs and symptoms of a sympathetic nervous response? Let's start with, you can start with like any part of it you remember. What about sympathetic? What do you remember? What happens in that fight or flight?
I don't know if this is what you're looking for, but vasoconstriction or vasodilation.
Okay, so in the body, what is going to take place? So you're right, we're going to have vasoconstriction. So blood vessels constrict. Okay, what else? As you have this fight or flight response, what else happens?
Release of adrenaline.
Okay, we have epinephrine or adrenaline, epinephrine or norepinephrine response. So that release of adrenaline, you're right. Adrenals are secreting for sure. What else is happening? If your blood vessels constrict, we have an increase in heart rate.
Increase
Right?
heart.
What's that?
I just said increase in heart rate.
Yep, so blood vessels are constricting, we have an increase in heart rate. What's going to happen to the bronchioles?
They will constrict.
Expand.
So if you need to run fast, are your bronchioles going to be narrower or wider?
Wider.
You want them open, right?
Expanded, wider.
You want to be able to run. If they constrict, you can't take deep breaths. So bronchioles dilate. Bronchioles dilate, which we also have an increase in respiratory rate usually, right, in that response. What happens to your mouth? Does it have more saliva or does it get dry? It gets dry, right? Have you ever got scared and your mouth instantly gets dry, like, oh my gosh, like your tongue about sticks to the roof of your mouth? Feed and breed, remember, think of feed and breed, saliva. Where fight or flight, no, it dries it up. Everything constricts. What do you think happens to your pupils in the sympathetic nervous system?
They
Dilate.
They dilate, right. They dilate. Why are they dilating? Why are they dilating?
I know, but I don't know how to explain it.
They're dilating because they need to allow more light in, okay? Because they need to be aware. They need to be seeing everything. So excitability creates dilated pupils, okay? So pupils that are smaller and letting less light in is more of a parasympathetic response. So we have constricted pupils more normally or smaller. Can't write on there. All right, what else? Now what happens in the parasympathetic? So we talked about dry mouth here, saliva increases because now you're okay. What happens to the bronchioles in parasympathetic? go back to normal, right? Go back to normal. And you don't have any adrenaline that's going to need to be secreted because the adrenals are everything's calming down, so we don't need that. Saliva increases. Okay. Oh, I did it down here. Sorry. What happens to the heart rate?
Slows down.
Yep, just goes back down to normal, like equal or normal, goes back down. So it's been high, but now it's decreasing. So we have all of that, this immediate like freaked out response comes back to a slowly parachuting back down to normal to be able to get back to homeostasis and the balance that's there, right? So we have to be able to consider before we can start nervous system and the spinal injuries and spinal trauma, we have to understand what the nervous system regulates, okay? And I want to make sure that you kind of get that as we get started. And so a lot of that we covered in the beginning, but we definitely need to cover it again just to refresh your memory. So remember that sympathetic versus parasympathetic. And parachute should help you remember as it comes down, where that sympathetic is when your fight or flight system is responding. All right, so we're going to look at injuries that happen to the spine and mechanisms of injury. I want to get to the right one here. And before I go all the way in there and we start talking about the spine, I want you guys to mark page 803 in your book. I'm going to pull up my notes here. 803 in your book. We already talked about neck wounds and what we do for neck wounds. I do want you to highlight that patient care section in your book on open neck wound on 803. That way you have that for reference, and the picture is on 804, just so you know, so you can kind of see what you do and how that is managed. But that's a great kind of breakdown of that, so you can follow that. And that's about where we're starting right now with spinal injuries, in case you're following in your book, is on page 804. All right, so when we talked about the spinal column, we look at what we call the axial skeleton. What is included in the axial skeleton? What's the axial skeleton?
The extremities.
No.
Okay, then it's
The other one.
the other one. It's the brain, the lungs, the spine.
So it's the skeleton, the skeleton that we're looking at. The axial skeleton. So not the brain, but the skull.
Oh, okay.
Right? The spine.
Yes.
Do you guys remember that, what we talked about? And what's the appendicular skeleton? Okay, so extra credit, I want you guys to identify send me an email, what is the axial skeleton and the appendicular skeleton. It's not even gonna be extra credit, it's a required. I'll give you guys 5 points for sending it in. Email it to me this week, the axial skeleton and the appendicular.
Can you, yeah, I was gonna say, can you write them down?
I just touched on it when we did head. So the axial
I can see
skeleton.
the picture in my head.
Yep, it's in your book too. So the axial skeleton and the appendicular skeleton. Remember the word skeleton, so it should only include bones. Axial and appendicular. All right, so I kind of talked about when we took our quiz about the head and it weighing, like a human head weighs like close to 17 pounds. So when we start to think about injuries to the spine and what's there, we have to think about what are we talking about? Well, we're talking about a 17-pound bowling ball sitting on a fine structure of spinal bones that go all the way down through the back that are protecting a cord that literally runs every part of your body, every nerve ending, everything that goes through. So when we think about injuries to the spine, we really have to take into consideration how that head affects it. And what mechanism of injury they have is their risk of injuries to that spine. So your mechanism of injury in determining should I take spinal precautions is huge. I just had a patient the other day came in with a laceration to his head. And he said it was just, he's on blood thinners, and he said, I can't get it to quit bleeding. So he has his shirt, his long sleeve camo shirt, tied around for direct pressure on the back of his head. The knot is on the back of where the bleeding's at. It's holding it, it's doing fine. So anyways, lo and behold, it takes a little bit to get the whole story out of him, of what actually happened. And so I think we're only just dealing with a laceration, but it ended up that it's a gentleman that had been riding on an ATV. They were messing around in a gravel pit, going in circles. He did not have his seatbelt on. And him and his buddy were there doing it. His ATV caught, it threw him through his windshield and out onto the ground. So when he came in, I didn't know the whole story at first. I thought it was just a laceration, but then I got the whole story afterwards. Didn't know the actual speed, just spinning around and spinning around. So I take a look at the injury on the back of his head to take a peek at the wound that's there, and it's a tiny little puncture wound. So the puncture wound is literally like not even as big as a pencil. It was very small, just just kind of like a hole poked in there with some skin around it scraped. Underneath that puncture was a huge hematoma that was approximately like the size, probably, it was bigger than my fist, but probably about, let me get all my hands empty, about that big, that was complete jelly in the back of his head where blood had accumulated between the skull itself and the outside tissue. So as a result of that, that's why he kept bleeding. It was bleeding in that area, and it kept leaking out that. He was on blood thinners. He had significant bruise on the back of his thigh, shoulder hurting, and ribs hurting. So once we got the whole story, there was more than just a laceration. But that mechanism of injury, he comes in, he says, I don't have neck pain, but I hit my head, or I somehow got a puncture in the back of my head, a laceration, and I can't get it to quit bleeding. So my question instantly in that situation is, do I want to put him in a C-collar right now? So I have to decide, well, okay, tell me a little more what's happening. Well, I'm looking at him with his camo shirt tied around his head. And like, what's happening? And what did you do? So he explains, I was riding the ATV, it threw me out the window, I landed on the ground. Did you lose consciousness? No. Are you having any cervical pain? No. Well, I feel stiff in my shoulder area, but I'm not having really pain in my spine and my neck. Okay, palpate the whole area. So would I or wouldn't I, as a result of the mechanism of injury, want to apply a C-collar? What are your thoughts on that? You guys tell me, what would you do?
I'd be putting a C-collar on him.
Okay, all right. Anybody else?
There's
If we
no,
were at the scene, I would.
Okay, so I'm in the hospital.
But you're in the ER.
Yep, I'm seeing him in the ER, but I still have to decide, same
You
thing. So
do?
if you saw him a half an hour to hour after this happened, and he told you all that went on, would you put a C-collar on him? That's what I'm
And I
asking.
would, yes.
Okay. Anybody
there
disagree?
there is no negative impact on placing a C-collar. So yes, it can't hurt.
Okay, so I agree. So why did I determine that? Well, he does have some shoulder pain, which tells me he hit something with his shoulder. He does have this hematoma on the back of his head, which I can pretty well figure out it's related to his blood thinners that he's on. And but I am not comfortable knowing he was thrown through the windshield, which the window opening, and out of it onto the ground. So I opted for the C-collar. Mechanism of injury, determining if I should or shouldn't. It is literally over a half hour since he had it happen. However, do I want him moving in the bed, turning his head and looking at me till I can prove otherwise? No. Understand, when you're looking at mechanism of injury and you're deciding how should I care for this patient, we might rule out using a backboard, and we're going to talk about that. But a C-collar, if there is any indication that there was a mechanism significant enough to cause injury or that makes you suspicious, by all means, trust your gut. It's not going to hurt to not. You're right. Absolutely, Jude. Put it on, because we definitely could be sorry we didn't in hindsight. So did I think the mechanism was enough? Yep. He obviously hit his head on something that punctured the back of his head. His shoulder is hurt. That tells me this area took injury or impact. So I'm going to put it on. Now, I want you to understand that when we think about that, we think about axial loading, or we think about the head, the weight, how it hit, what hit, extension, severe extension or severe flexion, more than what's normal. We don't know. So we take precautions because we understand that regardless of how structured and strong that spinal cord is, and it is freaking strong. I watch a orthopedic beat on it with a hammer to get things into it. It is strong as heck. But what's underneath is the vital part of our being, and being able to have pulses, motor, sensory, all of our feeling and what goes on. So do we want to preserve that? Absolutely. So we take that precaution, knowing that it reminds us and the patient that they don't need to move their neck. We don't want them to move their neck. All right. Now, sizing that C-collar is, again, the most important thing too, because if you put too tall of C-collar on a patient that has a cervical injury, you'll actually separate the bone and cause further spinal cord injury. So you have to make sure that you're sizing it. If you had a pediatric patient that you are needing to immobilize the spine, and you don't have a pediatric actual C-collar, then use a towel roll. But you have to be able to immobilize when it's necessary, because movement in that area can cause severe damage. And we're going to talk about certain things between that. Now, that spinal cord, basically, like I told you about the electrical box and all the wires coming out, it is basically that relay from the brain to the body and back again. So it definitely has a huge part of us being able to interact, to move, and have vital organs be able to be managed. So keep thinking about what that is and why it's so important. And when you think about it, it handles every single part of the body function. Everything needs a nerve to stimulate it, and to turn it on and to turn it off, and to make it move and make it move back or stop movement. All of it revolves through that brain and spinal cord. So we want to remember that, okay? Because of that big head, or that 17-pound average bowling ball on top of your neck, there's a lot of injuries that can happen just as a result of that head, whether it's whiplash, side-to-side movement, overextension, if it is a hanging and we pull apart that cervical spine, those kinds of things. Primary and secondary injuries, they can be directly related to that or as a result. So whether you have complete damage to a cervical cord or to your cord in your spine, or as a result of swelling or bone injuries or fractures related to swelling, secondary injuries that cause pressure on the cord, both of them can be super significant in how the body is affected by it. So when we think about mechanisms, what do we want to think about? Well, here's some examples. First of all, if you are in a car accident and unrestrained, think about the mechanism. What did they hit? They went forward, they came back. All of that weight of body and head and neck. And if you've ever been shoved in the back, what happens? Your body goes forward, but your head goes back. Opposite directions can cause actual fractures of the vertebrae. If we're thinking about it, we look at people who are diving or who will fall off like head first. We have significant flexion, and you can see that girl that's in the pool upside down. Her chin is hitting her chest significantly as she hits the bottom of that pool. Same thing in whiplash in car accidents. If we don't have our headrest where it needs to be, then that whiplash can also take place. And we have what we call a significant acceleration, deceleration injury. All right, and we'll get into that as we go, but I want you just to kind of get familiar with hearing it. So we're always going to look at what is the mechanism, because we have a 17-pound at least bowling ball on an average adult's head flinging around or moving or changing the direction of that spine. So some of the mechanisms of a significant, let me see. Before I go any further, hold on, I'm just gonna put something on the board. So we determine our mechanism of injury, all right? So we're doing that in our scene size up. We're determining our mechanism of injury. So this is in scene size up. All right, after we determine our mechanism of injury, then we're gonna go through our physical assessment. We're gonna see what is actually wrong with the patient and what do we suspect might be wrong as a result of that mechanism of injury. Some things are obvious, some things are not obvious. And as we talk about neurogenic shock, that's what we're looking for. What is not so obvious that maybe we're missing, okay? So what kind of mechanisms are we looking at that are high risk for spinal injuries? Well, falls, usually greater than 3 feet, down more than 5 stairs. Now, if we added pediatrics to this, or older adults, then we can see where it would start to change in height and in how far they fall. An older adult can just fall from standing, and because of the osteoporosis or the bone brittleness in their spines, they can actually have injuries that you and I might not have. So we have to take into consideration age definitely plays a factor. And we also take into consideration that if we have, let's say I'm just gonna draw a head of an older adult, you and I's spine, we come down, so if they're looking ahead like this, our spine comes down and goes down like that, and we have our legs and our arms. An older adult's spine comes off their neck, and they might get this big hump, and then they have that, and the arms are a little low, they have that big curvature right there, right? So now if we think about the weight of the head on a spine that starts to curve right off of the neck because of osteoporosis, we can understand why they would be so much more significantly impacted if they actually fell or if something happens. Plus they have brittle bones. Axial loading is what we call compression injuries. And what happens is the axial load, or that diving injury that we just showed, where the head hits the bottom first, the load hits and it compresses on the spine. We see compression fractures in that. Axial loading, that's what that is compression fractures as a result of the axial, remember the axial skeleton starts at the skull, that axial load onto the spinal cord. And it can actually fracture the vertebrae, and then as a result of the fractures, then we can have swelling and maybe impingement or pinching of the nerves in the actual cord itself. High-speed motor crash, vehicle crashes, rollovers with ejections. Start to think of how bodies move. We don't just sail out like a superhero in a cartoon. We go in all directions, and that weight of the head is a significant heavy area to where body will follow a lot of times because of the way that the head on the neck does sit. So any significant mechanism, again, energy that forces the movement of the spine beyond the normal range. So if your head goes back too far or too far forward, more than its normal range, or side motion, it can stretch and put pressure onto that spinal cord. So that's definitely something we want to consider. High risks, again, ATV crashes. My gentleman that was in the ATV, he looked like somebody took a bat to him because of his blood thinners. But once I got the whole story, he's on Plavix, which is a blood thinner. Kind of a unique thing about this patient. I'm starting to wonder what in the world, but 3 years ago I had him. He's 54 years old. He was 51 at that time. I had him for a stroke. Last year, the same week in May as this week, we had him for a seizure that he had at his cabin. He lives in Rochester Hills, and he comes up once a year with all of his buddies and has a big drinking party and bash, and they do fun, crazy stuff, and he ends up in our ER for the last 3 years. So a year ago, a seizure. This year, the same weekend, because it's always the same nurses, he asked if we worked all the time because we're the same 3 that he always sees, because it's always our weekend when he comes, same every year. He came in this time with his ATV accident. So this gentleman has Plavix as a result of his stroke that he had 3 years ago. He also takes an 81 milligram of aspirin. So if we're talking about blood thinners and we're talking about injuries, so take in consideration, we're talking about mechanisms of injury that are significant. Then we have to consider when we get our sample that we're also asking about, do you take any blood thinners? Increases the risk significantly. So he takes 81 milligrams of aspirin, the small dose, and the Plavix. Well, because he was hurting so bad and he didn't want to come in, his buddy said, well, I have some aspirin in my truck. How about I'll give you a couple of those? I take them for pain. So he also gave this gentleman 325 milligrams of aspirin times 2. So not only did he already have thin blood from all of that, the reason we were seeing such significant, horrible bruising and blood collection was because he literally had water. And then add alcohol as a factor that thins your blood too. So he was literally like thinner than water inside. So was this a significant mechanism now? Heck yeah, definitely. Because not only did he have potential for risk of injury, any injuries he had were going to bleed without a doubt. So understanding mechanisms and what happened and understanding people's other comorbidities or problems they have is super important. That's why a lot of times asking, are you on any blood thinners? That's what you want to know. Or saying, do you take aspirin or do you take any blood thinners? Some people don't count aspirin as blood thinner because they take it for cardiac. But we have a higher degree of suspicion in injuries related to patients that are on blood thinners. As you assess, very rarely when you assess a spine will you ever feel a deformity. It's not very common to feel deformities in the spine. What is most common is you feel pain and tenderness. So if your patient says, oh, that hurts, or oh, that's tender, and you're palpating that cervical spine and going down the actual thoracic, lumbar, and sacral regions to the coccyx, if you're palpating those and they say it's tender, that is a clear indication to you that, something's going on. There's no clear-cut sign in a spinal injury that is going to scream at you unless it's very, very significant and obvious, like there's paralysis or numbness and tingling. A lot of times initially, that's not what happens. They actually just feel tenderness and pain. But as things swell and as things change, it ends up getting worse. So keep that in mind. Dermatomes basically is what area of the body that the nerves go to, that the spinal nerves go to be able to tell that area how to respond or what to do in order to respond. So if you lose an area of a dermatome, then you can lose function from that area. So a dermatome is basically where those nerve endings go in different parts of the body. Let me see. On page 807 in your book, I think it's 807. That's your list of high-risk injuries, and on page 808, you'll see the dermatomes, the areas of the skin that are affected. All right, let's stop and take a break. It is 1934. Didn't realize that. Let's stop and take a break, and let's be back within 10 minutes, 1944. I gotta make a call to the hospital, it looks like. So we'll take 10 minutes, and then we'll be back. Clothes. Oh, so I yeah, so I have to get an order. We're waiting on. I'll get it for you. Go ahead and go. I'll get it for you when you're done. Joel's like, is that right? Yeah, it's just me.
So now I finally got you here, Laura. You got any information that I can start studying so I can get going on my advanced thing?
I just gave, oh shoot,
Like,
I just gave Joey, medics, a copy of 2 tests, like to practice. He's been doing a lot of other tests online, but I just gave him a copy of 2 tests, what are they called? Shirts. 2 tests to practice, answering them and see where he's at.
like
So,
that test online or something that like Jeff was doing and.
yeah,
people
so
ask me,
that one is expired now. I did it like for that right after their test, but you can sign up, I can sign it up if you want to do it. Then I can start it again if you think you'll answer it or do the online one, then I can do it. Start it for practice. If you want to do it.
Do you have to have a web? You have to do it.
Yeah. So you have to do it here or have it at home. Yeah. Do you have?
Yeah, I got it. And I was just like wondering because, you know, I was over there, I don't have to do that over there, and I was just like, you know, if I can do it, will help me.
Gotcha. Yeah, no, it is online program, so. the hospital may come to it, you know, that's how that breaks. But I'll sign it up if you wanna do it, I'll start it for you and I can show you how to do it, and then you get it on Wednesday.
And do you have that one book?
Josh, or no, Jim,
I don't know any other Christine, so. Okay, bye.
Do you have any shirts anywhere? Question mark. I was gonna look for one for Alex and I didn't see the box there, period. All right, let's see where we're at here. Okay, let's keep going with our spinal cord injuries and what we're expecting. So we talk about signs and symptoms and mechanism. If we're actually assessing the patient, then we might see signs of paralysis, or we might see signs of, sometimes it's just pain, and they can't really identify exactly. It's just an ache or it's a pain. And I've had trees fall on heads before that cervical spine injuries were present, and they ended up being actual fractures that we didn't realize was there. And all there was an ache or a constant pain that's there. Well, if you think about nerve pain, you can understand why there would be a pain there. Those dermatomes, or those areas of the body where the nerve endings go to, if they're injured, they send out an alarm that there's pain. So we might notice first that there's pain. Further in our assessments, we're also looking at the paralysis, feeling the numbness and tingling that they might feel, unable to move certain extremities. That's a bad sign, right? That paralysis that's there. But paresthesia, remember that word, paresthesia? That is that numbness, tingling, that tingling type sensation. And we might see that also. So pain without any movement, tenderness anywhere along the spine, and if they have any impaired breathing. And I always say, remember C5, the diaphragm is fully innervated between C3 and C5. So if your patient is having impaired breathing, listen to this closely, if your patient is having impaired breathing and you suspect, because of mechanism of injury, a spinal injury or a possible cervical injury, you need to remember that that could be an injury to the nerve that innervates the diaphragm, that phrenic nerve. So that phrenic nerve, and I'll write it up here again, is the one that innervates that diaphragm. And it's between C3 to C5, but primarily what you need to know is it's C5 or above, because that's the cutoff to it. So phrenic, P-H-R-E-N-I-C, phrenic nerve. Okay? So that's the nerve that innervates it. And if you have a possible spinal injury, you have to be aware that the diaphragm might not be moving, that the injury there could be related to damage to the nerve that helps the diaphragm move. If the diaphragm cannot move, then they cannot breathe adequately, and you have to be able to manage that. So make sure any spinal injury that your patient's having difficulty breathing, that's coming to your mind. Oh shoot, they can't breathe because they might have actual injury, or there might be pressure or swelling on that phrenic nerve that's causing that impaired breathing. Now, what does that mean to you? What does that mean? For all purposes out in the field, you're going to recognize it as inadequate breathing, right? Inadequate chest rise. It doesn't have, their mechanical ventilation is not working as it should. So inadequate respirations. In the field, doesn't really matter. However, you're going to treat it the same way as what I'm saying, like with oxygen and ventilating them, right? But when we stop to think about National Registry, what are they going to give you? They're going to give you signs and symptoms of injuries that should help you as a detective, an EMT detective looking for signs and symptoms. It should help lead you to the point of, oh shoot, that's a cervical injury. That the impaired breathing is probably related to damage to that nerve. And that is what is important in the spinal and for answering for National Registry. So out in the field, we don't need to call in report. We suspect there might be an injury or a fracture to between C3 and C5 because we don't have any diaphragmatic movement. We don't have to say all that. All we got to say is we're ventilating at a rate of, with high flow O2, the patient is unable to breathe on his own. So they know that's going on. We can say suspected cervical injury. We don't have to diagnose it right down to what it is because we don't know. But on National Registry, for your questions, you do need to be able to recognize that that is a sign and symptom of a cervical spine injury. So impaired breathing, all right? Labored breathing, shallow breathing, impaired breathing. Some of the other things that we might see as a result of spinal cord injuries is a priapism. So a priapism is that erection that is significantly painful. We're talking about an erection that is very, very painful. And as a result of that, the nerves that innervate that area that causes the erection creates it, but it doesn't allow it to relieve. So it stays in that erect state and it doesn't come down until the nerve damage or the nerve, what's going on there is taken care of or relieved. So a priapism, if you're assessing a patient, and we were saying in the beginning when we assess them and in class we assess, we verbalize the genitalia. Now, in a spinal injury or a significant mechanism of injury that we are concerned, we are going to palpate that area. And we're going to look at that area and decide if we see something that's out of line. All right. So keep in mind, sometimes you can't see or sometimes you can't palpate it well. With that being said, I can tell you from experience, my gentleman that was thrown on the snowmobile, he was thrown so far, but anyways, he was in full snowmobile gear. Now, at that point, my ex-husband was on the basic truck with me, and we knew he was unresponsive. We knew that we weren't getting much stimulation at the bottom of his foot, his hands, nothing. He wasn't moving well. He was showing signs of neurogenic shock. And before we got his turnout gear or his snowmobile gear off, my ex-husband had palpated, and he said, "Laura, I think he has a priapism." And I was like, all right. So he's like, just double check and tell me if that's what you think. I'm like, well, let's cut these off. So we cut everything off, and sure enough, he did. So we were confident at that point that we have a spinal injury at some point, and probably at least in the lower back, if not up higher. So that was a clear indication, because nobody unresponsive after they've been thrown like 100 feet off a hidden culvert in a snowmobile is probably going to just have an erection for no good reason. So very good sign that there's spinal injury. If they've lost bowel or bladder control, all right, so if they've wet themselves or they've had a bowel movement, that also is a sign that the nerves can no longer help hold it to keep everything inside, so they've let it go. So all your sphincters that keep your stool inside your body, your sphincters that keeps the pee inside your bladder and keeps it from leaking out, all of those kinds of things, they are nerved there to keep those muscles contracted until you have the urge to go and you need to relieve yourself. So because of that, those sphincters follow that. But if they have no control and they're no longer staying tight to keep things in, then everything will leak out. We talked about deformities, and if you see an actual deformity. If you see a deformity, it is bad. So definitely don't palpate, don't do things to make it worse. Be very careful with moving the patient and make sure that you're taking full consideration of C-spine. And we'll be doing some backboarding and all of that. I have a lot to teach you. We have a lot of practical to do. We'll learn standing backboarding. We're going to learn the KED board. We'll talk about those and see some pictures later. And long boards, short boards, all that kind of stuff. But with that being said, make sure that you pick the appropriate board to be able to secure them, especially if we're concerned that there's a spinal injury. Okay. All right, so we talked about geriatrics and fractured spines, basically in older adults and their brittle bones. That's definitely something that you want to take into consideration. All right, so what do I want to tell you about neurogenic shock? And I am going to turn to page 809. Is got some things about neurogenic shock, but I have a bunch more I want to be able to tell you so you guys can get it and understand it better. Back in our bleeding and shock chapter, they did touch on the hypovolemic or hemorrhagic, the cardiogenic, and the neurogenic. So remember neurogenic shock, when we talked about it, neurogenic shock was also called vasogenic, right? And I feel like maybe vasogenic gives us a little bit more of a clue of what actually is going to take place as a result of this type of shock and what goes on in the body. So vasogenic shock or neurogenic shock. So we understand that that vessels or vessels are affected, okay? So I like to think of it as kind of like vessel shock, all right? Because we talked about the sympathetic and the parasympathetic systems controlling the vasomotor. The sympathetic being able to constrict in order to increase heart rates, in order to increase respiratory rates, all of that kind of thing. To dilate bronchial muscles, to constrict them back down, all of that kind of goes through that neurogenic, sympathetic, parasympathetic response, right? So what actually happens in that situation and what goes on? Well, those nerves are coming down and innervating the vessels, right? So we have this vessel that is controlled by the actual nerves themselves. And those nerve impulses go to the arteries to tell them whether to constrict or to dilate. So basically, what are we talking about when we talk about neurogenic shock? It's usually from injuries that are high in the spinal cord. The sympathetic and parasympathetic nervous system, they are actually innervated a lot through the thoracic lumbar region. That's where all those nerves go in and out. But when we're talking about neurogenic and dealing with the vasogenic part of it, we're talking about higher in the cervical spine. Because you guys know, we talked about medulla, narrows down, comes through that foramen magnum, the hole in the bottom of the skull, and the spinal cord starts right from there and goes into the spine, right? So you understand that right there at that vasomotor center, right at the medulla, which is the top portion above the tail that goes into the spinal cord, that medulla is where all of the nerves and all of the messages are originated. Then after they originate, they're like, oh, I sense that there's too much CO2, or I sense that there's not enough oxygen, or I sense that I'm bleeding, so I'm going to vasoconstrict. All of those origination factors go through that medulla, but then the nerves are then stimulated right below. And that is where all of the vessel control happens. So typically when we see a patient with neurogenic or vasogenic shock, that is a patient with a high spinal injury, okay? So meaning it's up in the cervical area, all right? So we're looking at more in the high cervical area because it's related to being able to dilate and constrict the vessels. What happens when nerves are cut off or are injured or unable to actually send the messages to the rest of the body, those vessels that are keeping their tone, so the vessels are keeping their tone, constricting and dilating as they should, all of a sudden we cut off their connection, all right? So a vessel is no longer able to receive the message that it needs to constrict. And it no longer can get the message that it needs to constrict more. It can't get any message. So what happens once we cut off communication to that vessel? we lose the tone from constriction and the vessels dilate. All right? They open. They're holding tight because of the nerves that are there. They're keeping their tone because the nerves that are there ready to constrict or dilate. But as soon as they lose the nerve that tells them to keep their tone, they get flaccid and they dilate. Now, can you see why that's going to be a problem? Why is that going to be a problem if all of our vessels dilate?
Loss of blood pressure.
Awesome. Yep. I'm just going to put this loss of blood pressure. This creates a significant drop in blood pressure. Now, are we actually losing blood?
No.
No. You're right. No. This has nothing to do with blood loss. So there's no problem with blood loss. We just lost the communication center and the electrical box to the house. We've just cut it after it came out the box and started to go through to the house. All right. So we don't have anything to control it. Our blood pressure starts to tank because we don't have the ability to constrict or to manage the tone of the blood vessels. So they dilate. They still have the same amount of blood in them, but it doesn't matter because now the container is bigger. There's just, the blood doesn't fill it all up because they all dilate. So what happens then, or what is happening, is I want you to know, is it's basically an interruption to the peripheral nervous system. So what is our peripheral nervous system? What's the peripheral nervous system? If you check peripheral pulses, you guys know this.
Okay, I feel like this is a trick question, but is it your extremities?
I'm not National Registry. I promise. Yes, it's your extremities. So that peripheral circulation or that peripheral nervous system is the nerves that go to your extremities. So not only do our blood pressure or our blood vessels dilate and we get hypotensive, we also have an interruption to that peripheral nervous system. So that peripheral nervous system then no longer tells all of those vessels that they have to do. So messages get sent all the way down, right? Well, if we're cut off at a high spinal injury, then messages are not going to get to where they need to go. It's not going to go through. The connection has been cut. Think about cutting the wires below the electrical box. How much lights are you going to turn on if somebody cut them all off? None, right? They will not respond. You can flip the switch all day long in the room. Nothing is going through to the rest of the house because it's been cut off or injured. So we have an interruption to what goes out to the extremities too. So these blood vessels are dilating, and then there's no longer any information that's going to the nervous system, the peripheral nervous system. So then what happens? If we don't have any communication, what's going to happen to this stuff? What do we check when we're checking neuros intact? What are we looking for if we want to know, hey, are neuros intact? What do we want to know?
Pulse motor sensory.
Right, pulse motor sensory. So can you feel a pulse? Are you getting a good pulse at that peripheral point? Can you get them to move anything at that peripheral point? Can they feel you at that peripheral point? Depending on the injury, whether it's anterior or posterior cord, they might have sensation, but might not be able to move. Or they might have movement, but no sensation. So if you don't assess pulse, motor, and sensory in all four extremities, in all areas, you will not be able to rule out that there is actually an injury to the spinal cord. So we have to look at this. If there's an interruption to the peripheral nervous system, then we're probably likely not going to get pulse, or we're not going to get motor and sensory responses out of that. Does that make sense?
Yes.
Okay, so let's look at this. I hope you're all saying yes because you're pretty quiet. All right, so let's look at this. Think about it, common sense. If vessels constrict, let's talk about bleeding and shock for a second. If vessels constrict, what happens to the skin? Bleeding and shock, what happens to your skin?
Pale, cool, and clammy.
Okay, do you guys all agree?
Yep.
Okay, pale, cool, clammy, right? Why? Blood closer to the surface when it's constricted or further away?
Further away.
Further away.
Further away. Awesome. Way to go, Ryan. I love hearing your voice. Okay, so now let's think about this. We have lost our vessel tone, the ability to constrict them. They are dilating. So what do you think skin will feel like in a neurogenic shock with more blood coming closer to the skin?
Oh yeah. Warm and
Are we going to get
Right.
sweaty? No, we're not going to get sweaty. There's nothing there to tell it to get sweaty. It is going to be more warm and dry.
would
Okay.
it be flushed? Like would
Yes, it can be more. That's what I was going to go next. It's going to be more pink or more flushed because there's blood that's pooling there or blood that is closer to the surface there. So we're going to have warm, dry skin, but it's going to be more flushed, more red. Okay? So you're going to see more redness there. Does that make sense? So now hang with me, all right? Do you guys get this? You get this picture and what's going on, right? What I'm talking about. I'm going to try to keep you in the camera. All right, so let's draw a person. Here's my guy, because you guys know what a great artist I am. I'm going to take out that. All right, and so let's say we're talking about high spinal injuries. This is what we're going to see. If I have a high spinal injury that affects the whole body, the whole house, everywhere it goes, then I am going to see that warm, dry, flush skin everywhere. I will not see really pale, cool, pale anything, nothing like that. I'm going to see warm, flushed, dry skin. Now, what happens? That's if it's a high cervical injury, right? So if that's way up here on the guy, then we're going to see that, okay? So then what happens if I end up with a lumbar injury? Where is the electrical system cut off from now? Tara, go ahead. Can you see my guy? Here's his injury right there. Where is the electrical system cut off at? It's in the lumbar.
Your pelvis.
Right around the pelvis
Like
or the waist area.
Yeah, just
Yep.
below or just above the pelvis.
Yep, right. So my injury is here, all right? Can the cervical spine and the medulla and the spinal cord still send messages up here? Can it still send messages from
Yeah.
here?
yes.
Yes, it can. Can it send messages from that point down? I just cut off the bedroom
No.
in the bedrooms in the bathroom, huh? It cannot. All right. So if the injury is enough and it's a full spinal cord injury, it cannot send the messages all the way to the bottom if the injury is mid-back, like lumbar area. Okay. But up here, we're still good. We can still send the messages. So with that being said, what is going to happen to the vessels up here above the injury versus the vessels below the injury?
So the vessels below the injury would dilate,
Okay.
and the vessels above the injury would do whatever the medulla is still sending the message to do.
Okay. So does everybody agree with that or disagree?
I agree.
You agree? Okay. Everybody else? I got one agree.
I agree.
Okay. You're absolutely right. So what is so crazy about neurogenic shock and spinal injuries is if the injury is high, it affects the whole body. We see the vasodilation of all the vessels. The body is warm to the touch. It's pink to red, and flushed. So If the injury is lower there than that, from that point down, if the nerves are affected totally, then it cuts off at whatever point the injury is at and below. So with that being said, we might still have pale, cool, clammy skin up above the injury. Is this not crazy? But down below the injury, we might have warm, dry, red skin. Because why? Because we lost the ability to be able to regulate everything below or above, below the injury, but we have not lost the ability to regulate it above. So whatever part of the body is cut off or damaged, that part is going to have the effects. Now, could we still have sensation? Yes. Could we still have motor only of certain areas? Yes. Could we feel, we could feel pulses like up here, down here. We might not be able to feel the pulses as well, because the circulation is not getting through, or if the heart, if they can't circulate at all the blood, then we might not feel that, but we could. So there's no clear cut and dry of, oh, spinal injury for sure. There's no pulse, motor, and sensory. No, nerve tracks follow different things. Anterior to posterior cervical spine literally does manage sensation, motor, and vasomotor control. So you can have different parts of the spine that have injury. If your anterior spine has injury, then what functions the anterior spine is the area of the body that's going to be suffering from the damage. If it's your posterior spine, it can be that area of the body that suffers from that damage. So it doesn't necessarily mean just because it's an injury to the lumbar spine that everything's going to be cut off. It's whatever part of the spinal cord is getting the pressure on it. Okay, so neurogenic shock. What do you need to know for neurogenic shock? Basically, dry, warm skin. Doesn't feel that much different. It's dry, warm skin. The blood is closer to the surface, so we have pink to red above above the injury, or excuse me, below the injury, and above the injury, it could even feel more normal. So you might not have as flushed, or it could be pale, cool, and clammy, but below the injury, wherever the injury is, you can have warm, flushed red skin. So you have to kind of look at wherever that injury is and below. If you see signs of dilation of the vessels, you understand that that part of the body is affected and that there's some sort of neurogenic shock. Typically, we only see it in high spinals, but it's not always the case. It depends on what part of the spine is actually a problem. Now, what's the first thing we do when we notice a patient that has a spinal injury? Is take manual stabilization of the C-spine. Can we do anything for the neurogenic shock? Take manual stabilization of the C-spine, get a C-collar on, get them on a backboard, a long board, some sort of board to be able to secure that spine, because we do not want them moving at all. Bones can cause injury, swelling can cause injury. They need to get to the hospital as soon as possible. Just for, I want to just finish this. So decreased blood pressure, but I'm going to just write this so you guys have it to put in your notes. Decreased blood pressure, but the heart rate is pretty much normal. It's like between 60 to 80. There's no tachycardia there. It's pretty much a normal heart rate because that part of the brain is still functioning and it's able to do it. But the blood pressure itself, they get hypotension as a result of that dilation of the vessels, the loss of control within the actual vessel wall itself, not in the heart rate. That doesn't affect it. Okay, so just a FYI, anterior injuries are usually related to loss of sensation, to pain, but they can still feel light touch. So if they feel light touch, but you pinch them and they can't feel that, that could be as a result of an anterior injury. So remember, anterior versus posterior, anterior spine versus posterior, that's like what we're kind of talking about. So kind of just some interesting things. When we are treating the patient, a lot of times this is because of an actual spinal injury, but secondary injuries that we want to make sure that we're not missing. And that is that we don't miss the hypoxia. Remember, if we have a high spinal injury, that phrenic nerve that's innervating that diaphragm, we can get a patient that's very hypoxic because they're not able to breathe well on their own. So managing secondary injuries, you could get to a patient and recognize that they're unable to maintain their own airway, they are hypoxic, and they're not breathing well. And in your initial assessment, that in primary assessment, that doesn't tell us really anything other than I need to secure the C-spine because of the mechanism. I need to get the airway open in some sort of maneuver. I need to secure it. I need to oxygenate and ventilate, right? So we don't know yet what else did we find. Are we going to just see this out of the blue? No, not necessarily. We're going to be assessing them. We're going to find either pain or weird findings that are not consistent above versus below the injury. Or we're going to see that this patient has a very low blood pressure, but their heart rate is pretty much normal, right? So you're like, what's up with that? I might think if this was me that, oh, if I was a medic, oh, they're probably on a beta blocker and they don't have the ability to constrict or they don't have the ability to increase the heart rate. So that's probably why, unless it was a younger person. I might just sign that off because is spinal shock actually that obvious? Neurogenic shock is not that obvious. You find it when you are doing your secondary assessment, going through the patient, doing pulse motor and sensation, pulse motor and sensory, and following through with that. That's what you're actually finding out what's going on with this patient. Then you see that pink to red, dry, warm, very warm to the touch skin. Typically, people in an accident that are unresponsive should not be pink, warm, and dry, right? They should not look red, warm, and dry. They should be pale, cool, and clammy. They should be tachycardic. The low blood pressure, yeah, we might suspect that because of hypovolemic shock and internal injuries, but it isn't consistent with what else is going on and with our findings as we assess them. So one of the very keen, super cool ways of recognizing neurogenic shock, and that's really that warm, dry, red, pink to red skin, and the difference between where the injury is at, the upper body and the lower body. I find it super, super intriguing. Now, if the gentleman on the snowmobile, if he wouldn't have had the priapism, I would have still suspected spinal injury. I would have still C-collared and backboarded him. We were ventilating him. So I figured there was probably internal injuries. I didn't know anything, but I knew when I ran my pen up the bottom of his foot, he did not try to move anything. I knew when I tried to pinch him and I tried to do painful stimuli, I knew he wasn't responding well, but at times he would moan. So I knew he must be feeling something. When we got to the hospital, one of the very common things that a doctor will do when they have a spinal injury is they will do a rectal exam and actually feel up inside there and check for blood, because that can be significant in that situation. And when the doctor did that to the patient, he let out a huge holler, and we could tell that he was responding to pain. So we knew at that point, which most people would if somebody just drove their fingers up your rectum during an exam. And the doctor was not as gentle as he probably should have been with it. But we got a response out of the patient. It was the first response. So what did that tell me? Well, one, I know he didn't like it. But two, it really told me that he has painful stimulation. He has nerve tracts that are relaying messages at least to that point. So right there, at least we've got something that we can go off from. He did end up having a spinal injury, and he did have to have some surgery to be able to stabilize it because it was unstable fracture. But anyways, at that point, once that was done, he ended up with full mobility. He didn't have any deficits later as a result of it. So keep in mind neurogenic shock. It's a super cool type of shock. It's vasogenic, or like vessel shock is kind of what I call it, because the vessels are shocked. They don't know what to do, so they just shrug their shoulders and give up. So that doing that, they dilate. They don't have ability to hold tone. Does that make sense to you guys? You feel like you understand that?
For the most part.
Okay.
Yes.
Way to go. All right, good. How about Bryce and Sarah? You guys feel like do you have any questions about this? Does it make sense to you? Comment on there. Clayton, Ryan, feel free to ask. I'm sure if you have a question, somebody else definitely does too. I'm the question person all the time, so when I'm in a class, so I have lots of whys. Whoops, let me go see what. Chat, trying to do it. Makes sense to me, says Bryce. Okay. All right, so we've talked about shocks. We have neurogenic, vessel shock. We have hypovolemic or hemorrhagic, bleeding shock. We have cardiogenic shock, which is a pump problem, pump shock, heart shock. Basically, it's a problem with the pump. We had septic shock, which was also related to massive vasodilation that created low blood pressures. We had metabolic shock, what's related to diabetes, insulin shock with patients going into hypoglycemic or hyperglycemic type episodes. We had psychogenic shock, which is like a syncopal episode from fear, like a syncope. What else? Respiratory shock. We talked about respiratory is really related to a respiratory problem. What else? Our CHAMPS RN, right? Neurogenic. So cardiogenic, H, hypovolemic, A, anaphylactic, right? CHAMPS RN, A, I still use it too. Anaphylactic, that again is related to massive vasodilation with hypotension. I'm going to set up some scenarios for you guys when you come to class, and you're going to have patients that you will manage in those shocks. And the biggest thing is, one, that you recognize it in the signs and symptoms, and two, that you actually manage it. So the only way you can do that is by studying it and knowing it. So make sure that you're going over these and you feel pretty comfortable with being able to do that. All right, before we go on any further, let's talk about our picture. So our picture, and I'm not sure, Sarah Irvine, if you saw this or not. Let me take this out. This is our picture of an injury that I wanted you to think about. What are some of the things you're most concerned about, and what are you going to assess quickly or do quickly if you walked up and you immediately saw that? So we're going to start talking about that, and I'm not sure if you did see that picture when I put it up. So there's the picture. And I am going to start at the back of the room because in my mind, you guys still have your seats here you're supposed to be sitting in. And I'm going to start with Ryan. And I want to know, Ryan, what is one of the first things that you're considering when you saw that picture? What's one of the first things you wanted to know?
How severe is the bleeding?
Okay, awesome. So how severe is the bleeding? If I told you there was significant blood loss or significant bleeding, we look at that picture and what's around the gentleman on the actual ground and stuff and the potential for injuries there. What would you want to do with that, what you see there?
If you can't control the direct pressure, probably apply a tourniquet.
Yep, and looking at that, it's pretty significant, pretty large, so we probably aren't going to do very good with direct pressure, right? Because it really does cover a large area. But you're right. You're absolutely right. First step is direct pressure. If I can't control it by that, then I go to a tourniquet. I agree with you. I would probably apply a tourniquet also. All right, so if you thought of that as a major bleed and you apply the tourniquet, that's awesome. What else would you want to know or do with that injury? You ask me. Anything else? Go to Aaron. You're next.
I would look at maybe wrapping it, preventing any foreign debris from getting inside of it.
What's that? Do what?
Possibly wrapping it and preventing any foreign debris from getting inside of it.
Okay, so we're probably going to want to bandage. Before we bandage, what else are we thinking we might want to do?
Check for distal pulse.
Yay! You're right. Okay, so I was thinking of one other thing, but you're absolutely right. So check for a distal pulse. It don't look like there's going to be very much of a pulse there, but sometimes you're surprised at how much circulation is actually still there. I just had a gentleman, he's actually in our swing bed today, that came in yesterday that fell at home. And his right leg, he could no longer bear weight on it at all. I ended up having to get a Doppler to be able to assess his pulse. And I checked for a dorsal pedal pulse because I couldn't palpate it. So I went and got a little ultrasound Doppler that I put over the top trying to see if I had pulse. I had really poor capillary refill. It was greater than 4 seconds, but he also has some +3 pitting edema related to congestive heart failure. So I couldn't tell, is it related to the fall or is it related to the heart failure? Not sure, but I couldn't feel the pulse. So then I ended up going to the posterior tibial, which is, where is that page? I'm going to move up to front. Where is the posterior tibial? Do you remember that one?
I think it's a smaller bone in your lower leg.
Okay, the front or the back?
Be the back.
The back. High five, girl. You're right. Posterior tibial is the back of the tibia on the back of your ankle. So you go to behind the malleolus and you feel in that area for the pulse to feel if it's there. So I couldn't feel it palpating it, so I ended up using the Doppler again, and I got a very weak pulse, but that's all I needed. I needed to know there was circulation there. Can you feel it always? No. Can you report that I'm unable to palpate distal pulses? Yes. Okay. So in this patient, when we look at that, we're going to check for a pedal pulse. If we don't get a pedal pulse on the top, we're going to check for a dorsal pedal pulse. So, or dorsal or posterior tibial, because we want to know, okay, is there circulation going through this foot? Is all the vessels affected, or is there some still being able to circulate? So just because you check the top of the foot, don't mean you can't reach behind and check the bottom or the back. Also, we can do some cap refills to check for circulation, right? So keep that in mind. That's important. If you don't have pulses, excuse me, then what is something we want to consider? And now I'm to Olivia. Olivia, if you did not have a pulse and you weren't able to palpate it in that foot, what is something you want to consider?
Well, before that, I'm just focused on like shock O2, but like
That's
I don't
a
know.
good girl.
Is there anything you can really do if at that point?
That leg, it looks nasty.
I don't know. It's really messed up.
It is really messed up. Okay, so definitely considering shock specifically. Yeah, I'm sure he's probably going to be in shock. He's going to be in horrible pain. And oxygen and being able to treat the shock, keep him warm, right? That kind of thing. That's a great observation. I'm pretty sure he's going to be in shock too. So I'll take that for an answer. That's definitely something you'd want to consider. So let's move to Clayton. Clayton, what else would you want to do with this leg if you saw it?
Maybe like a splint.
Awesome. Yes. Yes. We're going to check for pulses. We'll check for motor and sensory. I don't know if he's going to be moving that leg very good, but we still check, because what are we looking for? We're looking for nerve endings. I'm not going to ask him to move his leg. I'm going to say, can you wiggle your toes? Do you feel me? Can you tell what toe I'm touching? I doubt that's anything that he's going to feel, but it's not probably related to paralysis from a spinal injury as much as it's related to complete leg injury, right? So awesome. You're going to splint it. So when you palpate it, let's see, let's move up front to Sarah. No, Bryce. Bryce, you're on the corner. I almost forgot. So when we palpate this pulse, we don't feel a pulse. So we want to splint it. So what do you want to do? And this is just kind of reviewing what we've covered in splinting. What do you want to do next? And just think about your rules of splinting, kind of like, what do we look for? What do we do? What's the whole systematic approach that we would do if we did not have a pulse and we need to splint this? So the splint is not applied yet, is what I want to say. The splint's not applied yet, but we're going to splint it. When we check for a pulse, no distal pulse. Do you know, Bryce? Attempt to readjust it once. Awesome. That's exactly what I'm looking for. So we're going to pick to splint it. First, what do we want to know? We want to know, do we have pulses? Do we have motor? Do we have sensory? Then we're going to look at no pulses. So we have one attempt to put it in the position of function and to readjust it in order to try to get a pulse back. So we slowly add traction, which, can you imagine traction on that leg? A little bit of traction, manual stabilization. Okay, Jude, that's fine. So then we have manual stabilization, and we have one attempt to put it back into alignment. And if we don't get a pulse, then that's it. We're splinting it anyways, right? It doesn't matter. So you're absolutely right. So we're going to check for distal pulses. We're going to try to realign or readjust it once to get a pulse. If we don't get a pulse, we're splinting it in the position found and securing it. Now, a lot of bone fragments there. You can tell the tibia is fractured and the fibula looks like it's fractured too. So both the bones are fractured in the lower leg. So definitely going to cause a problem. So we get this splint applied and we have it secured on there. And Sarah Irvine, if you are still on, what do you want to do after you have applied this splint? What would you like to do? Check for a distal pulse. Awesome. Yep, we recheck for pulses. So remember, pulse, motor, sensory. So distal pulse, you're absolutely right, motor and sensory. Could we have, if we had no motor and sensory prior to that injury, could we have motor and sensory after splinting it and putting it in position? Is that something that we would even suspect or expect to find? Janelle, tell me that one.
Yes.
Yes, right. Because sometimes it doesn't mean the nerve is completely severed. What it means is that, I missed Olivia in the middle. No, I got Olivia. We got it. Okay, wait, I'm like going around the room still looking. Yeah, so what we want to make sure is that maybe we've realigned it to where if it was pinched or twisted, now by putting it back, we've taken the pressure off and oh, some of that sensation is actually coming together. Yeah, Olivia was my shock girl. That's for sure. Shock it is. All right. Is there anything else that you want to do for this patient that we have not covered yet? Feel free to say so.
Did that happen from a fall or a jump from up high? Because if so, you want to do C-spine.
Okay, awesome. What actually was the mechanism of injury? That's a great observation. What actually caused that? So that way you know how you want to manage or handle that. Yep, you're absolutely right. Okay, I am going to show you another picture. Let me just see which one I want. Okay, here it comes. Can you guys see that? I'll take it out of the thing. I wish we were in class so we could do these group things.
And I'll put my popcorn away now.
Oh man, if I saw this, I would be like, oh yeah, hand me the popcorn.
You probably like the Saw movies too, don't you?
I just like, oh my gosh, I want an evisceration so bad. So we look at this, you can tell it is an evisceration, right? You see the belly button, you see the guts coming out the side. That's part of the colon that's there. You see that?
So what does that actually cause from a laceration?
Yep, it can be caused from a laceration or significant pressure where there's actually a perforation in the bowel or in the side.
Have you ever seen it?
I have seen it, but it has never been in the field to where I actually got to put my hands on it.
Oh,
So it wasn't my patient. I know, I wanted it to be my patient, but it wasn't the patient. Okay, so we see this patient, all right, and they present into or that you get called out for this, and they say that it's an abdominal injury of a motorcycle driver. So he has lost control, and you arrive on scene, and this is the first thing that you see, okay? First thing you see. So let's go to Tara. Jude had to step away for a second. He'll be back in a little bit. So Tara, what is the first thing you're considering when you see that?
You want to keep it covered. You don't want debris to get in it, so keep a moist dressing on it.
Okay, so we see that, and we want to make sure that we keep a moist dressing on it. Right, so when we treat it, we're going to make sure that we get a moist, thick, bulky dressing on it to be able to put over top of it. Absolutely. All right. What else do we want to do? And Sarah Lermont, I'm recording it for her, so she is not here tonight. So let's go up to Danielle. Danielle, what else do you want to do for this patient?
So you could put the occlusive dressing over the moist dressing.
Yep. So next could be you put your occlusive dressing over the moist dressing. So we have just applied our moist dressing. We put our occlusive dressing over top of it. So now we have it safe from environmental exposure or from getting more possible debris or anything else in it. I can tell you usually the hole that the colon and the evisceration comes out of is not always very big, that a lot of times that evisceration will come out and it's sticking outside of the body and the hole is very small. So with that being said, sometimes we might not see pink organs like this one. So this hole is plenty big enough, but we might see actually purple organs or black organs because they're ischemic, because the pressure against the hole and what's pushed out has cut off circulation. So we have this patient that is got a bulky dressing. We have an occlusive over top of it, and we need to take care of him. What else are we going to consider? Well, what else do we want to do, Deidre?
Treat for shock, keep them warm.
Okay, treat for shock and keep him warm. Absolutely, because he's probably going to be shocky. Is he going to be having abdominal pain?
Probably.
Oh,
yeah.
Absolutely. So he's going to be in pain. Whenever we know organs or that there's ischemia, so if you saw blackness to this or like a dusky color, remember as quick as you can high flow O2, because whether you see ischemia in an organ or you see like cyanosis on lips, that tells you cells and tissues are not getting the oxygen they need. So if that was the case and we saw this and it was purple, we're going to give them oxygen also. We're also treating for shock, because if they have this going on and they hit hard enough to cause this, then they probably had significant abdominal injuries and things are probably also going on inside. There's still something that we want to do. So let's move back to Ryan. And Ryan, what else do you think you would want to do with this patient, or you could do?
Not sure.
Okay. Aaron, do you have any comment?
Not really. Like everyone kind of said the main thing. I mean, all you can really do is just check for your pulses all around and maybe have them sit with their legs kinked up a little bit.
There you go.
Okay.
Imperative part of treatment. You got it. Imperative part of treatment for evisceration. Remember when I told you if they are supine laying with their legs all the way stretched out, what does it do to the abdominal muscles? What happens to those abdominal muscles if their legs are straightened out?
It causes them to,
Pulls on them, right?
Correct.
It pulls it tight, so it creates more pressure. It causes more organs to go up. What happens when we flex the knees and bring them up?
It takes the pressure off of it.
Right, it takes the pressure off, it relaxes them. As much as it's important, first things first, bulky wet dressing over top of moist dressing over top of that. Bulky dressing over top of that injury, occlusive dressing, but make sure those knees are up, because if you have it pulling tight, you're creating more ischemia and more damage. Bring those knees up. Might it kind of sink in a little bit? It could, but we want to make sure that we are able to bring them up to take off that pressure that's on there. That's a vital part of the treatment of an evisceration. So don't forget those three things: knees up, occlusive dressing with the moist dressing underneath. So you're going to put your moist dressing, your occlusive dressing, and make sure the knees are up. Now I'm probably, if I find a patient that's supine laying on the floor, probably I'm going to make sure those knees are elevated. However, for National Registry, what they really want you to know first is you cover it up in order to protect it. So cover it up in order to make sure it's okay, and that there's no actual debris or anything from the outside getting in, because that's definitely a problem. Okay. All right, I got another one for you. I gotta find it though. Okay. This is what, let me take this out. This is what you see.
Is that a burn child?
Yep. So that's what you see. Okay.
That'd be
So
contact.
only head. So I want you to think about that for a second. This area of the head, that's a burn. It's a scald burn.
Oh.
So I just want you to see what that is. And let's start to talk about that soft tissue injury and what we're concerned about with that. And we are up to Paige. So Paige, what are some of the things that you're going to be most concerned about if you walked in and you saw that? And that, I would guess that baby probably to be around like about a year, not quite, between 9 months and a year old.
I'm not sure where to start.
Okay, that's okay. How about Olivia? What are you thinking?
Airway.
Airway. Okay, definitely. So what are you considering? What are you considering about the airway?
Did whatever burned him get in his mouth? Is it swelling?
Okay, lips, anything like that. So this is a scald burn, and what happened is the child pulled a hot fluid, and I don't know if it was coffee or water or what, down onto his head. So that's where this burn came from. So that's what we're kind of looking at. So we are definitely concerned. Are the lips swelling? Did it get anywhere that might occlude the airway? So airway is definitely a problem. Janelle, did you get to see that picture or no? Janelle, did you see the picture? I know you got booted off. Maybe she still got booted off. Are you there, Janelle?
Yeah, I don't know.
Did you see
Rusty's
the
on
picture?
a Zoom meeting right now too, so he's sucking our internet. So I don't know if that's maybe why too.
Okay. Did you see the picture?
I did not.
Okay, so I'm going to show it.
Oh,
This is like between 9 months and a year old. It's a scald burn from him pulling down liquid, some hot liquid down onto him. So that's the one we're talking about. And Olivia said airway, and considering airway, it looks like he's sucking the pacifier. So that's definitely a good thing. What else do we want to know? So Clayton, what are some of the things you're considering right now if you were the EMT that you wanted to assess or find out?
Maybe cover both the eyes. Looks like the one eye has some damage.
Okay, his eyes definitely look like the one eye is burned, doesn't it? So that might be something that we consider. Okay, yeah, in the other eye, it's hard to say if it got in the eye. That right eye definitely looks like he has some burn to it. And remember, let's identify these burns. Let's look at what we're looking at here. So typically we call, what do we consider this? First or second degree burns, or both, or third degree? What are we looking at? Clayton, tell me, what one do you see?
I say second.
Okay, second degree, right? Because of blisters. Jude, what do you see? Go ahead. I missed you when you left.
Yeah, sorry I had to leave, but
That's
I
okay.
definitely see first and second.
Okay, so first and second, we do have some blistering. We do have some not blistering, but red. I am quite concerned about what happened around this eye. And like Clayton was mentioning, is this actually, this is thin tissue and thin skin. Did it miss it because of the eye and the eyebrow? Or is this actually a whiter, waxier surface that has deeper burn? And I'm also concerned about what's right there. Because I have all this burn all the way around there, but this one spot right there that has that kind of white waxy appearance. So I can't really tell if that is
the nose looks waxy too.
yeah, if you look at the nose, that area of the nose, it's burned on both sides. So did it hit one side and go over, or is the burn actually deeper? So hard to definitely tell exactly what's there. So let's look at, so we're thinking about first degree, second degree. We know first degree are mostly just that red superficial. Second degree, we have the blisters involved. Third degree, full thickness. Hard to tell. However, there's one thing that we do know about this, and that is that there's a percentage that goes along with it. So I want you guys all to take a minute, and I will show you the picture again, and I want you to decide what you think the percentage of burn is. And I'm just going to tell you that this is burned to just this side of the back of the head. So behind his ear, this area right here. So when it came down, it hit him there. So this area right here, behind his ear also has some, but it's not circumferential in the back of the head, just the side that has the most burn on it. So I want you to just look at that and decide what you think the percentage is of burn that's there.
Did we decide on the age? Was it over 1 or under
Nope,
1?
he's going to be under 1.
Under 1. Okay.
Yep. So I'll let you guys work on that or think that through. Okay, let's talk about it. What percentage of burns do you think that he has? So you've seen his face in that area, and I told you he has it just on the back behind the ear, kind of at the halfway mark of the back of the head. So I am going to start with Danielle. Give me the number you figured. I'm going right around the room, so be prepared just to figure your number and to say it. Danielle, what did you get?
12 maybe? I don't know.
Okay. Deidre, what'd you get?
13.5.
Okay. Bryce and Sarah, post yours, what you guys got for as far as the burn. Janelle, what did you get? Oh, Bryce has 18, he said. All right. Janelle, what did you get?
I am undecided whether or not it's 18 or whether it's a little bit more than that. It's kind of hard to tell because it's not circumferential, so it doesn't go all the way around the head, but it's definitely 50%. But is it more? I don't know.
Okay. All right. So, let's see. Clayton, what did you get?
14.
Okay. Olivia, what did you get?
I'm gonna say probably 15.
Okay. Paige? Are you there, Paige? Ryan, what did you get?
18.
Okay. Sarah, Aaron, what did you get?
I took an educated guess and got 15.
Okay, an educated guess and got 15. Okay.
Let's face it, if you're unseen, you ain't gonna pull out a calculator and do that. You're gonna take that.
Okay. And Sarah says 18. So let's go to our burn chapter and let's pull it up. Let's see. It's going to be page
704.
701 or 704. Yep. I was going to say right around 70 something. Okay, so we have a head that is 18% total, right? So front and back,
No.
front and back torso. Adult head is fully 9 and a pediatric head is 18. The torso for an infant or up to a year old would be closer to 18 front, 18 back. So that one should be 30.
Okay.
So 18, you were thinking 18 front if you looked at the picture.
Yeah, that's I was
Yep.
a little bit confused because I was looking at that. Yep.
So 18 is a whole head of an infant. So we don't quite have 18, but we have a lot of that area. So we know we have most of the facial area, which I would say is 9, most of it, right? Would you guys agree with me?
Agreed.
Yep.
Yeah.
Yes.
Okay, so I kind of, if I was figuring it, I would think that, yeah, Bryce says yes too. I would think most of this area, so I'm going to count that. Definitely the eyes and that are there, so which is significant. But so we have 9 there, and we have half of this area back here. So if I had the full head, I have 18. So I would use 9 plus 4.5. That's what I would use. So 13 to 14% is about what I would guesstimate to as far as what's there. And depending on if it was a little bit of the neck or something like that, it might be a little bit more. But that's about where we're at. So remember, 18 would be the whole head. So front is 9, back is 9, and we can kind of figure it from there. So good job. Way to work through it. We'll do some more of those. I have another injury for you. You guys ready for it? Let's see, which one do I want next? All right, so this is the injury right there, okay? That's the injury. Surfboarding got thrown into the sand from a wave and the surfboard caught him right in the center. And this is what you see when you get there. Okay? So that's what you see when you get there. So this was the injury. And that's what you see when you get there. All right, so let's start with, I don't know where I
Did I
left.
see the picture again? I had a stupid virus protection pop up.
Oh, that's okay. So this is the injury.
This is why you don't move to California and surf.
That's the injury. And this is what you find when you get there. So this is the side of him, and this is his abdomen. Okay, so first things first, and I'm going to start at the back with Jude. Jude, what is your biggest concern, or what would you be thinking that you want to know or you want to assess about this patient?
I would pallitate, excuse me, make sure there's no internal bleeding, check for tenderness, hardness.
Okay, and when you palpate that abdomen, I'm going to tell you that it is firm around the umbilicus and that he winces to pain. Okay? So Tara, what else do you want to know?
I don't know. I'm drawing a blank.
Okay. All right. So let's move to Sarah Lermont is off tonight. So let's go back up to Aaron. You're looking at it. What do you want to know?
No, I'm looking at possible internal bleeding from it.
Okay. So I did say he's got firm abdomen around the umbilicus when you palpate it. So what else do you want to know?
I don't know. I'm kind of stumped on that.
Okay. That's okay. Ryan, what are you thinking? That's why we're working through it.
Any of the organs damaged, I guess.
Okay. Okay, so Jude said he'd palpate the abdomen. You feel pain, you feel rigidity or firmness around the umbilicus, and if organs are injured, what organs are you thinking about if you see that bruising that's there? What's crossing your mind? Or looking at the mechanism of injury, what's crossing your mind that you'd be concerned about the injuries?
The abdominal aorta or spleen or something along those lines.
Okay, something that's going to bleed, absolutely. The abdominal aorta comes right through the middle there, the spleen significantly. If we've already got blood around the umbilicus, we definitely could have blood coming from somewhere in there. So a spleen, absolutely. Good. What else do you want to know? I'm going to go up front to Danielle because I missed that row. Sorry, Danielle. I need you people back. What else do you want to know about this patient, or would you do?
Well, I mean, I would check his vitals to check for shock. I mean, blood
Okay.
pressure, all that kind of stuff.
Yep, awesome. You want to know what is his vitals. How bad is this internal bleeding, and what stage of shock are we in? Are we going to suspect shock? Absolutely. What I need to know when I get to him and I see him like that is it compensated or decompensated? That is almost always my question when I walk up to a patient that I see significant mechanism for abdominal injuries to be internal bleeding, or if I see external bleeding. The one thing I want to know is how bad is this bleeding and what has the body done right now? So are they compensating still or decompensating? Because that changes everything about what I'm going to do. I'm going to manage and prepare to be aggressive if it's compensated. If it's decompensated, I've got no time. I've got to be aggressive, and I got to be aggressive quick and treat for shock. So absolutely, that's a great point. I agree. All right, Deidre, what else would you want to do? Or would you want to ask or no?
Oof, I don't know. Give him oxygen. I got nothing right now.
Yeah, well, okay, well, oxygen, and as we treat for shock, we would do that. Would any of you consider,
I have a question, Laura.
Sure.
Okay, so the bruising around the umbilicus and the bruising on the sides, isn't that later signs of internal bleeding, like the Gullens and the
Yep.
Grace Turner?
Yep, awesome.
So
It
when
is
did
later
this
sign.
mechanism, or when did this occur? How long have they been waiting for us? You know,
Awesome.
kind of stuff like that's running through my head.
That is an awesome observation. So Cullen sign and Gray Turners are usually later signs. That bruising comes to the surface. It takes time for what's inside to build up and actually come to the surface. Some things will bruise instantly because of in the tissue bruising, but Cullen's and Gray Turners are usually a later sign. So what else is going on? How long has this patient been down? When did this happen? And what's going on? That is an awesome observation, Tara. That's exactly what I'm looking for. Do you recognize what do these signs tell you? You guys are all on track with what is the shock? How are we going to treat him? Those kinds of things. There's one more thing that I'm looking for. If you saw this mechanism that you might be thinking, there's one more thing I'm looking for. Maybe 2 or 3 more things.
What about a spinal injury? If you
Okay.
came over the board.
Oh, you beat me, Tara.
Yep.
Tara, sorry.
Yep.
Was it
Spinal
a
injury.
short board or a long board?
It looks like half the board's in his abdomen. I don't know. But if that caught him like that, could that pressure have gone through when he hit it that hard? Could there have been an overextension right there of where his spine is? Could he have stretched it beyond what it should be? Absolutely. What do I want to know? I not only want to see that injury and see the bruising and what's there, but I want to know, does he have pulse, motor, and sensory below the injury? Because that's a pretty significant area where something could show it. So absolutely, manual stabilization of the C-spine. That's probably the first thing I'm going to look at. If they tell me that he caught his surfboard right to the abdomen and it catapulted him onto the sand, I'm definitely going to be considering that. Now, I also look at where that injury is at. So we're seeing, let's say we're seeing the bruising, but what else do you see there? What else does it make you consider or want to know?
Do you want to flex the knees?
Okay, it might definitely help because there's not any evisceration, but it definitely might help because he's got some serious probably pain there, and holding him tight would definitely help. That's a good point, Ryan. What else would you be thinking about? I'm thinking about ribs too. I look at that and I think, oh gosh, like that is not only abdominal, that's right about where the diaphragm, the ribs, like how far and how much of that went in and what happened with that. That's definitely something that I would consider. Now, anything, Bryce or Sarah, that you guys think you would consider? All right. They're not responding yet. Other possible injuries to arms or legs. Yep, assessing the rest of him. If he got flung like that, we probably are going to be able to look to assess other areas and see, is there any other injuries? If we've got that significant of a mechanism to cause that much damage, then the momentum or the mechanism definitely could be significant.
I was just wondering, like, are we concerned about airway? Because could that cause him to, like, vomit? I mean,
Probably, yep, airway. And me, like, I'm thinking diaphragm area. Did it herniate or rupture the diaphragm? Then we lose the ability to breathe, like that kind of thing. All of that definitely would be crossing my mind. And I would think too, like, as far as airway, for sure. Yeah, for sure. Okay, I got another picture for you. I'm trying to decide, do you guys want a medical or still keep going with the soft tissues?
surprising.
Issues.
Soft tissues, okay. All right. I have a crush injury or a burn. I'm going to show you another burn. Okay, so this is your patient when you get to him.
Yeah, that's what happens when you hit those vapes. Remember that, Bryce?
All right, so that's what you see when you get to your patient. He is unresponsive, okay? So he is unresponsive, and that's how you find him. So I'm going to go to Sarah Urbide. What is one of the first things you're going to think about when you see that patient? Airway. Yeah, it's kind of screaming airway, isn't it? You're absolutely right. Kind of screaming airway. What are we seeing with that airway? Why are we so concerned? What is it about that airway? Because we don't even know if he's snoring respirations. We don't know anything, but we know we're concerned about the airway. So you're absolutely right, Sarah. So let me see. Did I get around? Janelle, what would you be considering? What would be your next thought process of what you want to know? Or what you want to do, whichever. Treatment or questions.
I want to get oxygen on him.
Okay, definitely want to get oxygen on him, right?
Yes.
And I'm going to say I'm going to tell you guys this. I'm going to change the scenario just a touch so we can take it a bit further. Let's say that he is still responsive. So he is still responding to you. So we are going to get oxygen on him. You're absolutely right. I'm going to go back to Clayton. What would you want to do, or what would you want to know next? Or what would you want to ask me, if maybe a question or something you'd want to know or ask the patient?
Yeah, I'm drawing a blank.
Okay, Olivia, how can you help him out?
What caused this?
Okay, so he ended up coming out of a house, had an inhalation injury, and he said that when he was coming through, let's make something. Hold on, let me look at this. I do have scenarios. I should be just reading them. Oh, let's see, that doesn't match it. Let's just say, yeah, vape, right? Let's just say that he was in a burning house. He was trapped inside of it, and the fire department extricated him out. And he had attempted first to try to crawl on the floor to get out, but there was a lot of smoke and superheated air as he was coming through. So we would typically see singe burns. This is a really isolated airway burn, but you can see both pictures, kind of like up above and lower, the burns that are there. I don't have a good scenario for this one. Because typically we see more than just a tongue in that, but anyways. All right, so what else and what was he doing? Absolutely. What else, Olivia, do you want to know?
Like, listen for lung sounds, what's going on in there.
Awesome, awesome. Because if we see that there's actual burns to the oral airway, what do we really want to know? We want to know, how far does it go? How far does it go down? Is it affecting everything? Okay, so we might listen to lung sounds and we might hear some wheezing. All right, that's there. We might hear some crackles because of fluid. What else do we want to know? Paige, what else do you want to know? We're going to say he's responsive still, so just so you know.
I'm drawing a blank.
Okay, it's kind of tough, huh? Plus, we haven't done it in a little bit. Let's go up front. I did Aaron, Ryan. I'm getting everybody. I'm coming up. Let's go to Jude. What are you thinking?
I'll be checking his O2 sats. If
Okay.
and push comes to shove, use a nasal. Fairly. Yeah. I
Okay.
always. I'm sorry.
So maybe start a nasal cannula and start some oxygen on him. We could look and see basically what his O2 sats are and look for signs of hypoxia. Absolutely, that's a great finding. Not only can we do it through a pulse ox, but you're also going to be looking at his skin, right? Temperature, color, condition. That's the most perfect pulse ox there is. So temperature, color, condition, and that'll give us a good assessment at how well everything in his lungs are actually working. All right, so Tara, what else are you thinking about this patient? I'll show the picture again if anybody needs to see it.
I really hate to be this person. Can you recap it? I'm sorry, my children were.
Oh, that's okay. What else are you thinking? So Jude just said he would apply oxygen and check pulse ox, or check pulse ox and apply oxygen. I mentioned that we would look for skin color, temperature, and condition. So they have already said that they would listen to lung sounds and make sure that they can, what they hear. And I said you hear some wheezing and possibly crackles. So that's kind of where we're at. Anything else you can think you want to know or how you would assess the patient in order to determine what's going on? We're going to say this is like an inhalation injury.
Okay, so he has an inhalation injury. He's on the oxygen already. What about like a nebulizer treatment, or if he has a history of any asthma that would be aggravated by this injury?
From the smoke, possibly. Okay, so might have wheezing as a result of smoke inhalation. Okay, so what else? I'm thinking of one more thing, and I'm going to move up front to Danielle. What else would you be thinking that maybe you want to know or you could assess that would give you an idea of something? Think about inhalation or superheated air or smoke inhalation that gets inside. What are some of the things that we look for or that we suspect or that helps us identify how bad this really is?
I don't know, Laura.
Okay.
The only thing I could think of, another thing that I would do is have suction ready, because I doubt he would really be able to swallow.
Okay, so could
I don't know as far as treat. I don't know what you're
that's a
asking.
great.
I
That's
have
a
no idea.
great. That's a great observation as far as suction. Anybody else think of anything? Deidre, can you think of anything you'd want to ask or no?
No, you're killing me. I got nothing.
Okay, so what
about baseline vitals? Did we establish that we wanted baseline vitals yet?
Okay, so we could get vitals too, but I'm going to talk about specific to what is going on here. What typically, if we have an inhalation or a superheated air or a smoke inhalation or a burn to that area, what typically happens to the airway? How do we know that airway is open and clear? What are the things that we're looking for to determine?
Coughing?
Pardon me?
Coughing?
Okay, not really coughing, but they could maybe smoke inhalation with coughing. But what typically happens, Bryce, do you have any idea what typically happens when a person brings in the superheated air and it goes down their airway, into their lungs, into their throat, into their chest, or smoke inhalation, those kinds of things? What happens with that? Hold on, he's typing. Swelling and charring. Awesome. Now we're on a rabbit trail. All right. So possibly swelling and charring that's there. What does that swelling of the airway typically cause? What are you guys thinking, Sarah, Urbite, if you can just put it on there? What are you thinking it would cause if there's swelling in that airway? How would we know?
Difficulty breathing.
Okay, difficulty breathing, you're right. But there's
Like
specific...
stridor?
Yes, awesome. Stridor. Are we hearing stridor? Are we hearing swelling? Is the airway actually affected? How well is he breathing? Is this an intubation's got to happen immediately, or is he still maintaining his own airway or not? So stridor, stridorous respirations. Awesome. Yeah. If the patient is, if you have to ventilate them, so unresponsive versus responsive. Responsive, stridorous respirations, right, as they get swelling. So that's one of the things I want to know. How is his breathing? Is there any airway sounds, and what do they sound like? Second, if he's unresponsive, so responsive, he's breathing, talking, is his voice hoarse? Does it tell me that it's past the vocal cords? Remember, hoarseness, stridor, and if we ended up having to ventilate the patient, how much resistance are we meeting? Is it super hard to ventilate? That tells us that that airway is significantly compromised, there's swelling and it's closing, or are we still moving air good? So all of those things that we want to consider within that airway, as soon as we know that there's superheated air or smoke inhalation that's going to cause this massive inflammatory response, that's what's going to go on there. So good, way to work through it. Now you got some things to think about, right? Some soft tissue injuries.
That was hard.
I know, that one is hard. That's why I picked it. I did have a really good medical one, but I'll save it for when you guys come back when we work in it in a group. Okay, so we're going to go into, I want you guys to look over between now and Monday, multi-system trauma. So multi-system trauma is at the end of our, after the head, neck, and spine. And it really is just about multiple traumas with different complications. And we kind of cover that anyways, but I do want you to read through that. So it's going to be chapter, I think it's 30. Yeah, chapter 30. We're going to go through all of the spinal type injuries and all of that kind of stuff once you guys get in class, and we can cover that. I'm going to just squeeze through the PowerPoint, but those I want to do as we kind of get more hands-on, and we'll be going through all of those, and pediatrics. I want to teach you guys the helmets. I'm just going to squeeze through this real quick, but I do want you to read the multiple system trauma chapter 30 and have that read for Monday. I'm just going to touch base on a couple things on that. And then we're going to be going into operations, which will be EMS operations, chapter 36. I'm going to get to the helmets real quick because I want to talk to you about the helmets before we go. So if you have a patient that is wearing a helmet and it fits well, you don't always have to take it off. If it's not a compromised airway and the helmet fits snugly, you can leave it in place. The problem with a helmet is because it's got that big round part in the back, it can tip your head forward when you put them on a backboard, or it can go back because of the weight of it if it's not fit correctly. But if it's snug and doesn't allow movement, you can pad and leave the helmet on if you're concerned about removing it. So if there's no breathing issues, no airway issues, you don't have to worry, you can leave it on. If you're afraid that removal would cause further injury, so you have access to the airway, but they're saying that they can't feel you and you are not noticing sensation or movement like that, and you're worried that if you pull this helmet off, you might cause further damage, or there's compromise that's definitely there, then you can also leave it on. If you can't immobilize the spine with it in place, then you have to remove it. But if you can get proper immobilization by padding, then you can do it with the helmet on. You don't have to take it off. All right. You cannot have any airway problem. If there's an airway problem, it has to absolutely come off. So if the helmet doesn't fit well, I can tell you about a day I saw my son driving my daughter across the yard. He was pulling her on a sled and he was driving the snowmobile. And he had on a helmet, because I told him he was never allowed to do anything like that without a helmet. And he put the other adult helmet on Jalen, and she was about 7 years old. So I'm watching my son drive across this yard, and he's thinking it is hilarious to floor it and then stop, and floor it and then stop. So Jalen is literally flinging her head back and trying to get the weight of the helmet back up to hold on again to fling her head back. I literally ran outside into the snow in my bare feet screaming like a wild woman, because I was like, oh my gosh, the size of this helmet, the movement that's taking place, and what's going on with her head and the weight, it's gonna kill her. Like, I'm like, you're gonna paralyze her. So a helmet has to be properly fitted. You cannot have a helmet that's not properly fitted. And the same thing applies when we talk in EMS. If the helmet doesn't fit right, then we can't secure it, we can't align it, we can't immobilize it. So it has to come off. So if it interferes with airway, if it doesn't fit well, or you can't get them immobilized, it has to come off. I think cardiac arrest is pretty obvious, because you're not going to be able to manage an airway in cardiac arrest, if they're wearing the helmet. Okay. So also, we're going to talk about sports helmets. If you have a football player, and make sure you listen to this, because this is a common thing we see too. If you have a football player that has a helmet on and there's no airway compromise, then you can immobilize them with the shoulder pads and the helmet on. But if you think about a football uniform, if you take off the shoulder pads, what's going to happen with the helmet? Or if you take off the helmet and don't remove the shoulder pads, what's going to happen with the head, right? We're instantly going to have that fall back. So if it's a sports injury and you have to take off the helmet, you're taking off the helmet and you're going to have to take off the pads in order to get good alignment. If you don't have to take off the helmet, you're leaving the pads on. It's almost a perfect stable manual line of the spine if you leave both of those on. So as long as the airway is not compromised. Now, if something happens, the helmet and the shoulder pads have to be removed. Who is the best person to remove that? The EMT or the trainer?
Trainer.
Trainer. EMTs don't always know, unless they are trainers, how to actually remove that helmet. So make sure that you ask the trainer, even the coach, if he's there and he, that's who's training them, then that's fine. But that's who we want to do it, is someone that actually has that ability to remove it and know how to remove it. So don't just go pulling off a helmet. Not to mention, if you start cutting clips and everything, you got to be careful in how you remove it. They'll probably start screaming and hollering because it's going to cost a lot to fix it. But we've got to be able to get the face shield off if we have to access the airway. But I just want you to understand that the best person to remove a helmet is the trainer. We don't know anything about that stuff usually, and things change and are new. They also know where the padding's at, where everything is, how it's accessed, how it's put on and taken off, and they know how to do that. So that's who we're going to use. We are going to be very responsible for manual stabilization of that C-spine and manually holding the head while they remove it, because as soon as that comes off, we're going to have to keep that head in a manual inline position until the shoulder pads are removed, because it's going to be such a difference in height between the head and the shoulders. So keep that in mind. Helmets only come off when the airway is compromised, or they're improperly fitted, or you can't immobilize them. And keep in mind that when you tip a helmet, you have to get it off without manipulating their head. So I do have a sports helmet here. We can use other helmets if somebody wants to bring one in. But you always, on a snowmobile helmet or motorcycle helmet, you have to grasp the sides and pull apart a little bit so you don't actually manipulate the head. And it's super hard sometimes to actually get those off. But that's what needs to happen when you remove them. So you're not manipulating and pulling the head. You don't want to be lifting the head up either if we're concerned about a cervical injury. So helmets are a challenge definitely to get off, but something you want to get familiar with so that way you can. Any questions about helmet removal?
I'll bring my snowmobile helmet in because it's a real pain in the tuchus to get off. So
Okay, that'll be good. Yep.
I'll bring it.
As long as you don't mind, we're gonna put it on and off you.
No, that's
We'll
fine.
try not to take your nose off.
Mm.
Okay, so for I'm gonna post a quiz for head, neck, and spine injuries. That'll be coming up. I'll post it. It'll probably be up tomorrow, and I'll leave it open through Monday till we have class on Monday. And then I want you guys to read the multi-system.
We don't have class on Monday.
Wait a minute here.
No, Tuesday. Forgot Memorial Day.
Okay.
There's never a holiday hardly for me. I forget about them all. So Memorial Day, we will not have class. On Tuesday, we will have class, and Wednesday. So you'll have till Tuesday to do your quiz. That way, if you want to enjoy your long weekend, you'll be able to enjoy it.
Are we not having class on Wednesday?
We're
Wednesday.
class this Wednesday?
Oh, yeah, I'm sorry. Oh, my gosh, you guys, no. We have class on Wednesday.
No, it's okay. We can totally skip it. It's fine.
No, we don't want to do that. I just worked 4 days in a row, and I can't keep track of it at all. All right, so Wednesday, today feels like Wednesday to me. Wednesday is going to be, we'll cover the multi-system trauma, review that, and we're going to start ops. I will leave your quiz open until Tuesday, so you can do your head, spine, and neck until Tuesday of next week. Have it done before we have class on Tuesday. That's what I want to say. So you'll have plenty of time to study for it and to look at it. It is a challenging test. You are going to have to recognize the differences in shocks. So make sure that you read that. And I know head was challenging too. So make sure you study head, make sure you know the layers, where the bleeds are at, intracerebral, epidural, subdurals, what we're worried and concerned about, increased intracranial pressures. Make sure you study all that, how we manage that, what we're looking for. That's definitely something you want to be familiar with. And then on Wednesday, you're supposed to also be able to identify the axial and appendicular skeletons. So that way you know what those are without me having to remind you. And let's see, what else? Is that it? Okay, so no quiz till Wednesday this week. I will post your quiz. I'm not off, and I work tomorrow, so I'll post your quiz Wednesday morning, and it'll be up until the following Tuesday before class. So you'll have from Wednesday until the following Tuesday to be able to do it.
How do we know who's supposed to be coming in on Tuesday and who's supposed to be coming in on Wednesday? Are we doing that yet?
I'm waiting. No, because we have to wait till after the 28th. I think I'm still, if Linda will let me, I left her a message. Can I have 5 or 6 of you in here for that? And then split it up again. And she was here today just for a second, and I didn't get to really ask her again, and I kind of forgot. But I'll be emailing you, and I'll let you know. If we can do that, then we will have, we'll split it up. But if not, then we'll be doing it as soon as she lifts the what do you call it? Because isn't Memorial Day like on the 25th or something like that? I can't remember.
I honestly don't know.
Nobody knows. 25th, yeah, it's the 25th. So hopefully if everything gets situated, then hopefully we can just start doing that, and we'll do practicals. And if that's the case, then I will have probably someone, likely, hopefully Jason, if Jason's still there, do our hazmat. And because he was peeping in with Aaron. Jason, if we get back to class, hazmat, yes?
Yeah, but it's got to be in class because it can't be.
Yeah, that's what I said. If we get back to class, you would do it for me?
I will.
Oh, thank you. I'm like shaking my head. Yes, yes. He does it definitely a lot better than I do, and he can show you the books and go through all of that because that's something you're going to want to be familiar with. And then also, if we do get back to class, our triage, I definitely want to do that in class because that's important. And I have great drills and great practice and stuff that I want to do at the desks that I'm disappointed we haven't got to kind of do some of the other things. But we'll bring up the speed if that's the case. So study that for Wednesday and study your head, spine, and we'll be getting a quiz on that. And then I will see you Wednesday to start covering operations, EMS operations. Sound good?
Yep.
Okay, awesome. Nice job on your quizzes, by the way. I do want to tell you, as many as we argued about the questions, the scores were phenomenal. And I mean phenomenal. Like, I was geeked. I definitely had a lot of tough questions in there. I'm feeling you guys out for what you can handle and what you can't. And I definitely was impressed on how you handled the quiz and how you guys answered. So keep up the great work as far as that goes. Keep studying. You're doing everything right. I just got to get your hands on the tools and we will be able to go from there. So with that being said, I will see you guys Wednesday because, yeah, we do have class Wednesday. And we'll plan to go over axial and appendicular skeleton because you guys are going to have emailed me that or sent me it by message or something, so I know you know it. Until then, see you later.
Have a good night.
Okay, you too.
Thank you.